CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Dr. Alastair Younger, and is the head of the Distal Extremity Division in the Department of Orthopaedics. He's also president of the British Columbia Orthopaedics Association, and he works a lot with people at CHÉOS, and as such, he's a CHÉOS scientist as well. Alastair wears a number of hats. He's the founding member and past president of the Canadian Orthopaedic Foot and Ankle Society, and has been active on many committees of the Canadian Orthopaedic Association, the American Foot and Ankle Society, and the Arthroscopy Association of North America. Dr. Younger has been recognized by the Canadian Orthopaedic Association, being awarded 2 fellowships, and has represented British Columbia on a number of national committees. Today, he's going to talk about opportunities for the future in musculoskeletal research, understanding arthritis and bone healing. Thank you, Alastair, and go for it.
Thank you. So, when I sort of thought about this idea of work in progress, you know, I was kind of been inspired by the whole idea of the new St. Paul's. And my thought was to try and think, you know, where can we go? I know where we've been, and work in progress is kind of where we are, but I'd like to think about where we could go. So I'm going to share with you some ideas, and you know, this all sort of came around over the years of, I've been at St. Paul's now for 22 years, and I first came to Canada to do a master's degree in 1986. So, you know, sort of, anyway, these are sort of some of my reflections. I'm sorry, I haven't sort of done my conflicts, but I do work for some of the companies involved here, Stryker and Zimmer. I work as in consult. I don't get royalties. So just to sort of summarize, you know, what is orthopedics at Providence, you know, clinically, because we have a bit of a unique role, and obviously we do fracture surgery, and that's what every orthopedic surgeon does in the province. It's really 50% of orthopedic care. But we are also the foot and ankle service for the University of British Columbia and for the province. We're also the upper extremity service for the University of British Columbia and the province. And so that means we take all the sort of complex cases from other surgeons. And we also teach, and we do fellowships. So we teach medical students, residents, and fellows. And the fellows are surgeons who finish their training elsewhere in either Canada or the world, and they come to spend a year learning how to be foot and ankle surgeons. We also have postgraduate education, you know, for other surgeons and physicians, and we finally do research, and obviously that is what I'm here to talk about today. So, you know, why do orthopedic surgeons do research? This was a question raised by Jason Sutherland one day. He didn't understand why we did it, and a lot of research, when you look at it, isn't very good. You know, you kind of say, why would you publish, you know, a case series of 20 of this and 30 of that? And really it comes down to surgery is high risk and high reward for the patient, but it's also, you know, high risk for the surgeon. And our concern is to know that we're helping people and we're not harming them. So if you've come up with a difficult problem and you don't quite know your way around it, and you operate on it, and you want to tell other surgeons what you did and what roughly was the outcome, so that you know that if somebody else faces the same issue, then there's something that you can do to help them. We also need to know we're using resources effectively. You know, are we doing the most cost-effective operation, and are we providing, you know, patients, you know, lasting care? And finally, they need information about the outcomes of the operations we do. We initiated foot and ankle research with the Foot and Ankle Clinic in 2002, and at that point, we focused on ankle arthritis because the treatment before that point was essentially ankle fusion. And at that point, we started getting ankle joint replacements coming into the market, which are now fairly mainstream. And we wanted to know what the role of ankle replacement was. So we started a registry that's been going on since that time. We've obviously expanded in time. We've recruited new surgeons, and we've established a fellowship. The research office that we do this work from is based at St. Paul's. It's run by Biraj Bora, and he's been a master at co-opting volunteers and co-op students. And to date, we've trained approximately 80 co-op students, many of whom have gone on to medical school and other medical scientist type programs. So, you know, in its own little way, it's a little hive of academic activity. The fellowship program, we've trained 45 fellows to date from various countries. And we've been recognized as one of the top programs internationally, mainly because of our expansion in clinical areas. So what's our particular area of clinical expertise? Well, we've known for minimally invasive foot and ankle surgery. So the big bugbear in what we do is wound breakdown. And if you don't make an incision, then you're not going to get wound breakdown. And so a lot of what I'm going to talk about after this is to do with that issue. And also, we've been leaders in ankle arthritis and ankle joint replacement. So Dr. Penner has been on a design team of now the #1 used international ankle joint replacement. And he's also been involved in spearheading computerized guidance in ankle joint replacement. And all of this is focused into outcomes research. This is the ankle joint replacement that Dr. Penn has been involved in. I have no conflict showing this picture. It's Murray's baby, and we're all super proud of what he's done in developing this ankle. Dr. Velkovic and I do a lot of minimally invasive deformity correction and arthroscopic surgery. And this is really the moment in clinic when you stand back and you just go, have I harmed this patient? You do your surgery, it all goes well. You think you've done an excellent job. And this is the complication that is the one that makes us all stop in our tracks and fear that we've done more harm than good. And it really is the one complication that is difficult to deal with. And it's the one complication that potentially leads to amputation. And so, we started trying to work around it. And so this is an arch reconstruction that I did, and it was all done through stab incisions. And this is, so far as I'm aware, first time that this particular fusion has been done percutaneously. But it gives us a huge opportunity on how we can change things. And we've looked at these fusions done for hallux valgus surgery, and we found that they're more likely to fuse, that we're less likely to get wound complications, but we're in early stages. So this is some of the surgery that we've been doing in the minimally invasive surgery category, but this is to avoid getting into wound problems. So going back to where we started, we started with ankle arthritis investigation. And really, this is our ongoing research. We've collaborated a lot with CHÉOS on this and looked at the outcomes of what's happening to our patients. We have over 1,000 patients in the database. We have results beyond 15 years, which is really when things start telling for orthopedic surgery, because you want to know that what you do is going to be working in the future. But particularly with the new St. Paul's, it's a chance to sort of rethink and a chance to change what we do. So this book talks about built to last successful habits of visionary companies, but I could think that this could also be successful habits of visionary researchers, and you need to sort of change things up and have a big, hairy, audacious idea. This book talks about big, hairy, audacious ideas. It's really a great book to read. And it's a term coined by Jim Collins and his co-author. And it's essentially a big idea that is built on the long-term core values and purpose of your company. But we obviously have core values and purpose to our research. And the elements of this is it's got to feel achievable. It has to be clear and compelling. It expands your company's current capabilities. It's measurable. Is connected to the company's strategy and is long-term. So we're thinking 10 years and beyond, and that to me is sort of was resonant with what we're doing in the new St. Paul's. Some examples they give is, obviously Steve Jobs and the Apple computer was a big, hairy, audacious idea, stretching the imagination. And they quote companies such as Ford and the Ford Mustang as being big ideas that led companies forward, and also Microsoft and Bill Gates. So, I kind of sort of sat back and thought, well, how can we change what we do? Like if we're going to have a Lister moment in foot and ankle, what would that look like? Like inventing aseptic technique all over again. And how can we bring all of our tools together, industry, basic science, outcomes, surgery together, and something also that's meaningful. There's no point sort of disappearing off down a rabbit hole that does not appeal to donors and granting agencies, and ideally is multi-center. So that sort of led to me actually coming up with today's description of where could we go. We also need to build on past success, and obviously our research has been ankle arthritis database, but also we've done bone research, which was essentially sponsored studies in bone healing and bone graft substitutes. To just summarize where we've been with the registry, we now have, I know this is so small print, but over 800 patients enrolled. We're enrolling patients with open fusions, with arthroscopic fusions. So we started doing arthroscopic ankle fusions. I'm going to show you a paper on that in a little bit. And various ankle joint replacements, as you can see, some are discontinued and some are current. And so we sort of got information as to how things are changing in time. And so this is our follow-up cohort. These are ankle fusions in the pink, and in the blue are the ankle replacements. And this is our enrollment per year. So you can see it over the years, we've gradually increased our enrollment of patients. So we're enrolling approximately 90 patients per year. And this has allowed us to create collaborative papers. So this is one of them, which was a gender study paper. And it looks at the ankle joint replacements across Canada and how the outcomes differed between men and women. And so we've also collected outcomes in patients with ankle fusions and replacements, obviously, and we've compared the outcome to see really which is the best operation. So this was one paper that we did on satisfaction after both surgeries, comparing at that point in 2014. And we found essentially that the patients that had ankle replacements, while sort of more basic outcome measures may not show a difference, so tended to be more satisfied. This is our most quoted paper to date, and this is right at the beginning of our database. We're sort of thinking, how we're going to use this data, and this was back in 2008 when we published it, so 2006 roughly when we did the study, and there's a huge amount of resource being given to hip and knee joint replacement, and we felt that our patients weren't getting due recognition. And so we simply compared the preoperative function of people with ankle arthritis and hip replacements. And we showed that the patients with ankle arthritis were equally disabled, and that has improved our access to care. This is one of the studies that we did in collaboration with Jason Sutherland and the CHÉOS team. And we looked at the questions asked in outcome studies, and we felt that we could do better. And so in conjunction with Jason, we changed our outcome scoring. And another study that was done looking at work status. So many of our patients are in the working age group. And so this sort of addresses some of the financial issues that patients face, i.e. if they have surgery from us, are they going to go back to work? This was our most recent paper. This was a collaborative paper that we've done between us, Toronto and Halifax. So Toronto and Halifax have similar databases, and we agreed to follow the same outcomes. And we pooled our data. This actually, we still call it the gender study, but the journal changed it to sex, although this was sort of patient self-described gender. It wasn't, so specific on sex, but if the editors ask you to do it, I guess that's what we do. And we found that both benefited, men and women, and there was some differences in pain and function between men and women undergoing total ankle replacement and ankle arthrodesis. But when we brought in confounding factors, these differences disappeared. So this is really one of the things that I've learned a lot from CHÉOS and working with Jason and Hubert and Hong is, when we think we've got this fantastic result in surgery, we start bringing in advanced statistics, and then what you thought was fantastic isn't so great anymore, but that is good science. This just shows some of the demographic differences. Women tend to be younger when they get their ankle joint replacements, and they tend to have lower preoperative scores and lower long-term scores. And it may be due to the caregiver burden. Anyway, we showed obviously beneficial in both, and really not much difference in the reoperation rate. We also sort of in time have defined how we should measure reoperations, because one of the papers we did showed huge amount of variability in terminology. And if you're ever challenged by this, grab a bunch of papers where you think the terminology is inconsistent, review them, see how many terms are used, and then try and group them together and come up with a classification. This is our latest BC database paper, which is arthroscopic versus open ankle fusions. So arthroscopic is MIS. This is avoiding the big incisions. And we have more arthroscopic fusions now than open in time. And we found minimal differences in between the two groups. We found that there was actually a slightly better outcome at 1 year for the arthroscopic group, with trends for the arthroscopic to do better in outcomes, certainly less swelling, and in the perioperative period, less pain, and definitely fewer wound complications, which we demonstrated here. So infection was lower in the arthroscopic group, and we reviewed all of the outcomes of these. Monto, who's now a resident in Saskatchewan, reviewed this with us. The amputation rate was actually slightly higher in the open group, which may have been pre-selection for slightly worse cases. This is the long-term outcomes. This is actually going out to 250 months. So this is sort of the information that patients are interested in. So this is actually includes major reoperation of any sort. So you're going out to 200 months, your chance of maintaining an ankle fusion, whether it's done arthroscopic or open, is pretty good. Almost 90% survivorship out at this time period. So obviously we've got fewer and fewer patients followed long term, but this is very encouraging. We sort of begin to look at how we can collaborate. We've obviously collaborated across Canada, but there's now databases in the United Kingdom, in Duke and Seattle, and potentially the ability to collaborate with India. So Kishore Malpuri, our chair, is very keen that we should start doing this. Mo Bandari, who's a previous COA president and big into outcomes research in McMaster, has always been concerned about underpowered studies in orthopedics, and feels that if we can collaborate internationally, we will have a much better ability to predict outcome. And many of our outcome papers are essentially misleading because they're underpowered and sort of assume no difference between operative and non-operative, when in fact there may well be. So we listened to a talk this morning from data informatics at UBC, and this would be a fantastic application. We also have the only weight-bearing CT scanner in Canada, and this allows us to assess fusion rates and also assess weight-bearing alignment. So this is a flat foot deformity. You can see how the foot flattens out on this standing CT. When in a non-weight bearing CT or a spec CT is shown here, this is so similar flat foot does not collapse. So this is just sort of an example of how we can measure radiographic outcome in flat foot deformity, a recent case that was done, and showing the sort of the final X-ray view. So we've got a lot that we can potentially pool here: radiographic outcomes, alignment, patient-reported outcomes. And so Murray Penner has been busy working with our clinic to sort out how we can start getting weight-bearing CT on our patients. One of the studies we currently have going, or an RCT, which is investigator-initiated sponsored study, was looking at fusion rates using 2 different screw designs after subtalar fusion. And we've enrolled 73 out of our 94 anticipated. And what we're using as the outcome measure is a bit of a change in thinking. It's % bone healing. So when we look traditionally at outcomes for FDA analysis, for example, and bone graft studies and bone graft substitute studies, the FDA wants to know about union and non-union. And what we've been finding is that basically, if you look at a CT scan and you measure % bone healing, the more somebody heals, the less they hurt. And that sort of changes the way you think about bone healing. And if we can get greater degree of bone healing, patients will recover in a shorter period of time. They're less likely to go back to the operating room, which is obviously the previous metric, is whether or not they went back to the OR for non-union. But also, if they hurt less and recover in a shorter period of time, that's got to be good. And bone healing is so critical in fusion surgery, but also critical in fracture healing. So to date, we've had 1 repeat surgery in 1 screw design. And to date, we've shown no difference in the outcomes between the 2 screw designs, which, is hoping for a eureka moment here, but we haven't achieved it yet. But anyway, what we're learning a lot about in this study is about % bone healing and its relationship with outcomes. We've also been looking at SPEC CT, which is the addition of bone scan to CT, and that can be an improved measure of how well people are healing. We've studied a lot platelet-derived growth factor for ankle fusion, and the commercial name for this is Augment. So we've been working with the company to see if we can demonstrate better healing compared with no graft. Challenges for the future is sort of defining the extent of ankle arthritis. We've got old scales for this, which are really sort of 4 categories, but it really makes it difficult to talk about who's good for surgery and not for surgery. And obviously we need to look at MIS surgery. So I think we need collaboration and to try and understand better the basic science of both skin healing and bone healing as an opportunity going forward. And we need to evolve into research that's grant and donor focused and build on the expertise, because ankle arthritis, while interesting to patients with ankle arthritis, is not necessarily a huge appeal. I think that if we can look at bone and skin healing going forward, I think we'll be much wiser. Bone healing is obviously critical for fracture healing, and it's critical for fusion healing. It's also important for joint replacements, because many joint replacements are now uncemented, and the ingrowth surface is dependent on bone healing between the implant and the bone surface. And the #1 reason for failure in joint replacements is the failure of bones to heal, the joint replacement to heal to bone. And some of you may remember this particular set of ads that came out and have disappeared from the Vancouver Sun, and really sort of shows the mindset of many of our potential patients. For every patient we operate on with end-stage ankle arthritis, there's many patients out there with early arthritic change, and they're desperate for things to try and slow the advancement of arthritis. And the success of these clinics in bringing patients in, to me, was remarkable, but entirely unscientific. I mean, when they talk about regenerative medicine, we barely can comprehend slowing down degenerative medicine. And it was oversold to the patients and understudied, and now has become much under the scrutiny of Health Canada and the FDA. But to me, this is a huge opportunity going forward in growth factors to try and understand the true science of regeneration of bone and skin, but also arresting arthritis progression. So there's a lot that we could do here. So current research is looking at the amount of bone healing after fusion using advanced CT scan and how it could be affected by screw design and patient factors. Obviously, collaboration with the Heart-Lung Institute would allow us to better understand the basic science of bone healing and how we could make bone and skin heal faster and understand the growth factor deficits involved in this. Obviously, CHÉOS helps us understand the outcomes research we're doing. So if we can improve bone and skin healing, we can then look at patient outcomes and see how they've been affected. And that requires advanced statistical methods. We then sort of think, well, how do we fund it? And if we can get the right relationship with industry as we go forward, we obviously will learn more about growth factors and delivery methods and how it might affect skin healing and bone healing going forward. So, you know, we can do this better, and it's an opportunity, and it would give us the opportunity of developing new intellectual property to feed back into our research program and the researchers, because much of what we do continues to be funded by sponsored studies and investigator-initiated sponsored studies in the absence of being able to get grant funds. So this is just looking at CT healing of a fusion, and as we go through this fusion, we can see, you know, how much bone has healed across the fusion site, and if we measure this, this seems to tie in with outcome, and then this makes a much better measure for being able to look at outcomes of the effects of growth factors and anything else we will look at to try and work out how we get bones to heal better. So we need a legacy. We need to build research programs modeled on best practices. We need, obviously, to expand into basic science, to improve our outcome recording and make it more sustainable, to develop the relationships between departments and universities, to expand our international partners and build relationships with industry and protect IP to hopefully find ways of funding this for the future. So in summary, Foot and Ankle at Providence are world leaders in new technology and education and outcomes research, and the future may well be in bedside to bench. The successes to date have defined outcomes research in bone grafts, measurement of fusion, and patient-reported outcome measures, and ankle arthritis. So, you know, if I had to sort of model ourselves on anything, I would say we have to look at radiology and cardiac research, where they have good collaboration with industry. They've built on the experience in outcomes research. They brought the bedside back to the bench. Super impressed by what they're doing, looking at the valves, and we need to appeal to funding sources. You know, we have to look at what matters to patients, such as you know, early arthritic change. But I think we can get wealthy on our research. So I just want to acknowledge all the people who've been involved in this, our fellows, my colleagues, and our research office to get us to where we are today. So that's my presentation between surgeries, open to questions.